Sanjay Trivedi. So these are the moderator, and then we have the few panelists: Dr. Umesh Jadhav, Karthik Selvaraj, Vikram Maskar, Dr. Kanchan Bhattacharya, Manish Maheshwari, Anand Galgali, and Raghuver Reddy. So all these panelists will contribute in discussion, churning out in this paper presentation. So we are going to discuss each every aspect of that paper in great detail. So Rajendra, can you start your presentation?
Yes, sir, I will start.
Yeah, Rajendra, yes.
Yes, sir. So my paper is a
I'll,
femoral.
I'll just mute everyone. I'll just mute everyone. Hold on. Okay, Rajendra, go ahead.
Yes. So my paper is a femoral tunnel placement in an anterior ACL anterior cruciate ligament reconstruction intended versus achieved position for 221 international high volume ACL surgeons. So this is a paper which was published in the American Journal of Sports Medicine. So the background is femoral tunnel when it is not anatomically placed in ACL reconstruction. It is with the residual instability, graft rupture, and poor clinical outcome. So even the surgeons, they intend to place their femoral tunnels within the native ACL footprint. This is not always achieved. So this study assesses the variation between the intended and achieved femoral tunnel placement in a large cohort of experienced ACL surgeons. So the hypothesis is the accuracy with which the experienced ACL surgeons they achieve their intended femoral tunnel position is dependent on viewing portal, localization strategy, and drilling techniques. This is a controlled laboratory study device, laboratory study. So the graft placement, when clinical studies, they have demonstrated the common technical error resulting in instability or graft failure is non-anatomical graft placement, especially femoral tunnel position, which is closely correlates with poorer clinical outcomes. So different methods for the femoral graft site identification are clock face method, intercondylar and bifurcate ridge identification, the offset MR, then arthroscopic ruler measurement technique, and a fluoroscopy. So when anterolateral portal is used to view the femoral footprint, it is viewed when it is viewed tangentially and the arthroscope placed through the anterolateral portal. When the anteromedial portal is used, the view is more orthogonal. When accessory anteromedial portal is used with AM anteromedial portal as a viewing and anterolateral portal as a working portal, it has a better advantage. So what's the purpose of this study is to compare the different tunnel positioning techniques, and it was hypothesized that the accuracy of femoral tunnel localization, it might vary depending on the strategy of viewing and localizing the femoral attachment site, also with the drilling techniques. The current study, it represents the first large study assessing the variation between the intended and achieved femoral tunnel positions in a cohort of internationally high volume ACL surgeons. So in methods, around 221 surgeons from 23 countries who are high volume ACL surgeons, like who has done 40 ACL reconstruction in a year, were taken. The 8 cadaveric workshop blacks were identified. The representatives, they were from all over the world, like United States, Europe, Australia, Africa, India, Indian subcontinent, and the Middle East. Of these participants, the 62 surgeons, they were member of international ACL study group. So in every lab, a right-sided human fresh frozen cadaveric knee specimen was taken. A specimen was white donor. There were 6 females and 2 males with a mean average age of 61 years. The knee was mounted on a leg holder and the specimen was mid thigh and mid leg amputated. All the 3 portals were made. The diagnostic routine arthroscopic examination was done to see any damage for condyles, ligaments, cartilage. Then a C-arm image was taken with true lateral knee picture. Once the satisfactory positioning of the specimen was achieved, the position of the C-arm was locked. So this is a laboratory setup. In ACL, the native ACL was carefully divided and ligament fibers were resected. A great care was taken not to damage the femoral attachment site. To register the position of the femoral attachment site, a 45-degree microfracture owl was introduced through accessory anteromedial portal with a great care not to make any indentation in the bone. A tip of the microfracture owl was placed at 10 to different 15 points with a periphery of the femoral attachment site, and at each position a true lateral fluoroscopic image was captured, thus creating a trace around the periphery of the ACL femoral attachment site. So this is the picture. So like 10 to 15 points were taken on the femoral attachment site with a microfracture out. So to simulate a situation where the soft tissue attachments are not there, as in case of the chronic ACL rupture or a revision case, all the soft tissues, they were resected using a radio frequency ablation. A care was taken to preserve all the bony landmarks and cartilage border. So in intended tunnel position questionnaires, each participant surgeon, he was asked to complete a questionnaire to determine the nature of their ACL surgical practice, the tunnel placement strategies, and the use of viewing portals using arthroscopy. The surgeon then were asked to mark and cross their intended position for the center of their femoral tunnel on the diagram. So in a native ACL footprint, each surgeon was asked to cross on the diagram to demonstrate the intended center for their femoral tunnels. The shaded area which has indicated the anteromedial and the posterolateral parts of native ACL footprint. Then the assessment of the achieved tunnel position. After collection of questionnaires, each participant or the surgeon, he was brought to the laboratory and he was asked arthroscopically to demonstrate his or her selected ACL femoral tunnel position on the specimen. After surgeons were satisfactorily oriented arthroscopically, they proceeded to use their ACL tunnel placement strategy stated in their questionnaires. The participants, they were given all the instruments and they for finding their desired tunnel position, like a offset aimer, ACL ruler, outside in technique, and so on. So the position of the center of their proposed femoral ACL reconstruction tunnel, it was indicated by the resting or 45-degree microfracture owl against the lateral intercondylar notch wall, and then the image intensifier was used to capture that location. For those surgeons who are using an offset aimer, a guide wire tip was placed through the aimer and it was held against the bone instead of the microfracture owl. The great care was taken to not to indent the bone and the mark the specimen to ensure that each participant was blinded from the selected position of others. So the different tunnel localization strategy which were used were image intensifier, ACL ruler technique, the offset aimers, and the Regis face clock, these techniques. So this is one of the picture where the ACL ruler placement was used as a technique. So after the owl was positioned to the surgeon's satisfaction, a fluoroscopic image was taken, and the surgeon was blinded from seeing the fluoroscopic image unless and until he uses the fluoroscopy as his tunnel placement strategy. How the data was analyzed, the achieved and intended tunnel positions, they were measured by the independent observer who was blinded to the names of surgeons, their tunnel localization strategy, and their viewing portal used. The grid method of Bernard, which was used, applied to the fluoroscopic true lateral image, allowing each intended and achieved tunnel position to be defined as a percentage ratio of sagittal diameter of whole lateral condyle measured along the Blumenstadt line, which is x-axis, and a percentage of maximum width of the femoral condyle perpendicular to the Blumenstadt line, that is y-axis. So this is a picture where the x-axis and y-axis has been shown, and they have marked an intended and the achieved position of the femoral tunnels. So with this model, the difference between the intended and achieved femoral ACL tunnel positions, they were expressed as a vector, like the Euclidean distance. The magnitude of this vector, it was calculated using the Pythagorean theorem, which gives a value of a distance between the points as 0 for a perfect match. Means if intended and achieved, if they match, then the value will be 0. So an intended and achieved femoral tunnel positions for all participating surgeons as shown in a true lateral radiograph of the knee, which is relative to the grade of Bernard et al. This is one of the sample specimen 3, which is shown in this picture. So what was the result of this? The data from the questionnaire shows that all the surgeons who intended to place the center of their femoral ACL reconstruction tunnel within the native ACL footprint site, a mean intended location was 27% along the Blumenfeld line, 31.4% of the width of the femoral condyle, and the mean achieved position was 24x on the x at 24.7% and 32.1% on y-axis. So the out of 221, 181 surgeons, they achieved a femoral tunnel within the native ACL footprint, and 40 surgeons, they achieved a position outside the native ACL footprint. So depending on that, the viewing strategy, out of these, the 134 participants, they have made an anteromedial, they have seen the footprint from the anteromedial portal, and 87 they chose anterolateral portal. So anteromedial viewers, they were more likely to achieve a femoral tunnel position closer to their intended position as those viewing from the anterolateral portal. So 36% of AL viewers, they were outside, and only 7% of anteromedial portal viewers, they were outside. So the mean achieved position from AL viewers, it was also higher and deeper in intercondylar notch. So the localization techniques, those surgeons who used offset MR, they were 30% outside and they had a largest mean distance. Those who uses ridges and clock face, they had 25% were outside, and the ACL ruler, it was almost 8% outside, which was closer mean distance. And fluoroscopy, they were most accurate and they were all inside. Sorry for the spelling mistake. The drilling techniques, there was no significant difference found in accuracy among the 3 drilling techniques. Only the people who has used a transtibial technique, they found the position of the tunnel was higher in intercondylar notch and also vertical. So the discussion, the current study is first to assess the accuracy with which a large cohort of experienced ACL surgeons from around the world locate their intended femoral tunnel position for ACL reconstruction. So this study findings were that the accuracy, it appeared to differ according to viewing techniques and a tunnel localization strategy. So what were the limitations? So limitation was transtibial technique, where they found that the tunnel position is higher and even the tibial tunnel is not made to localize the tunnel position. Then the second, it was the specimens. They were amputated mid femur and mid tibia. So the offset MRs, most of the times for positioning and this thing, it was difficult. And also the mean age was 61.4 years, means the older age, but ACL reconstruction is done in younger age. So it was unclear regarding the ridges and everything. So the conclusion of this study was shown that even high volume surgeons may not achieve their intended femoral tunnel position. Also, it is best to achieve the femoral tunnel position through anteromedial portal and accessory anteromedial portal, utilizing a malleable ACL ruler or using fluoroscopy. So it is helpful for those surgeons who are using anterolateral portal and the other methods to gain their femoral tunnels. Thank you.
Paper open for discussion. It is depending on to the, hello, can you hear me?
Yes.
Yes.
Completely dependent on the ACL tunnel. So
I think in
yes.
one of the PKCs, this was tried live,
Yes,
if I
yes,
remember correctly,
yes, yes.
that they had called actually 6 to 7 surgeons and they had reproduced the same finding, which they have displayed in the this paper. And personally, sometimes after the ACL, I'm always thinking whether this tunnel could have been slightly here or slightly there. So uh, after so many ACL reconstruction, I feel that reproducibility, millimeter here or there, is always in doubt. After even though we are doing the frequent ACL reconstruction, so we have to make it reproducible by using one of this technique. Ruler I used to use, I have abandoned now. Somehow, my problem with ruler is that I cannot engage into the posterior part of the condyle. So there are no rulers available which can give me exact, end of the condyle when you introduce it. You have to assume rather that this is overhanging or this is correct. So I tried bending that ruler and getting the, new laser marking, but that was also not very successful. And then I got tired in between and I just left the ruler technique.
Okay. But where do you put the ruler from? Which portal?
So I view
Sanjay,
from the intromedial
where do you put the
portal.
ruler from?
Yes, I view from the intromedial portal, and my anterolateral portal is right side by the side of the patellar tendon, and I bend this ruler according to it is a malleable ruler. So according to the tunnel position, I
Correct.
try to bend it. Condyle position, I
But
try to
have you
bend it.
tried putting it through the?
Intermedial
What
port.
you do is, no, you put
Hmm.
the ruler through trans patellar tendon.
So
When
in
you put the,
sir, yes, I have
yeah,
tried that, and transporter portal. It was remaining too off the anterior part of the condyle. That was another issue with that.
Yeah, there are many issues with ruler, and I
The
think
main issue I found was I could keep my malleable rubber flush to it, but I just like our arthroscopic depth gauge, which we use to measure the tunnel, if there is something to hook, that could be a reproducible uh, positioning
Ar-
of that ruler.
Arthrex has that wand which can be used that way.
Right,
You know,
right.
so that has got a hook. You can go right behind. You can look from the medial portal. But I think
Hmm.
one trick is to see that where your articular cartilage is of the femoral condyle,
Hmm.
and you trace yourself back from there. That way you will never go wrong, because the fibrous kitna bhi purana reh lo, the fibrous tissue and the appearance of where the footprint is
Hmm.
entirely different. And once you are at the articular surface, then you can come that much more anterior. Okay,
Right, because
and
I
therefore you
always
can
intend to put it posterior to the center of this, in
correct.
ruler technique, I want posterocentral only.
You're right.
how
Correct.
many people use the Bernard rectangular system for
Is
diagnosis?
it available, Roshan?
It's not
Actually, it
available,
was
but you can use CM. No?
no.
See, that institute technique.
Sir, actually, when
Bola.
this Bernard and Hestel was
हो
designed,
कर
they did
ना ना
post-operative.
100% करायची.
Post-operative tech.
Post
Acha, oh, I
it
see.
was when it was invented first time. Bernard found
Right,
it
right.
was a post-operative. Then based on that, he came with that square.
Okay, okay, okay.
Raghu,
And one of
Raghuveer?
the also disadvantage was only the point was taken in this study. It was not whole tunnel. It was just the point,
Point.
the starting point on a femoral condyle which was taken, not the whole tunnel.
So what is interesting to see here is that normally it's been shown that the tunnel is very rarely circular. It's usually elliptical. And viewing it through an X-ray, especially with the kind of contrast you use, it is virtually impossible to draw a circle of best fit. That would be the ideal way of doing it. You draw a circle of best fit around the tunnel, the mouth of the tunnel, and mark its center. But on an X-ray with the Bernard technique, that's almost impossible to do. The only plausible way of doing it is a 3D CT scan with subtracting the medial condyle so that you see an end-on position of the lateral wall of the notch, and then you draw a circle of best fit and see whether you have managed to achieve it. Otherwise, more often than not, you will be disappointed by this
But
technique because
Vikram,
you may be able.
starting point of the tunnel is more important than which way it is going, because attachment is usually not very deep. It is just a starting point of the tunnel which is important. So even if it is round or elliptical, it really doesn't matter. Just get in the center of that elliptical, or maybe little millimeter here and there, but should not be too much off. So I think starting point is more important than the real direction and position of the tunnel. There's sometimes a correct position. I have found my button in the posterior part of the condyle when there is a very short height patient.
So, but as you rightly said, you're dealing with very small distances in the lateral wall of the notch. So, when you're seeing the starting point, what you're seeing on a lateral X-ray, it has to be a true lateral, number one, when you're seeing it. Now, when you're seeing a true lateral, are you seeing the whole starting point or only part of the starting point? So, when you're dealing with such small distances, you may be disappointed even while being right at times. So,
But who
that's
is
one.
using the X-ray? I want to know. I'm really interested to know. In day-to-day life, who is using the X-ray? Roshan, are you able to use it in your
I,
institute?
I have used one of my students was doing thesis. So that time
Thesis.
I have
Okay.
used X-ray, and to my surprise, the X-ray makes your life very easy. The only thing is, uh, makes it very easy because it's a new technique. Like you want to fondle, fiddle it around. You can put your probe everywhere and try to check out the exact position. But I think it's a time consuming. It takes at least 15-20 minutes extra of your surgical time to use radiology during the ACL reconstruction.
So that is what they have done one study also, whether the using Siam in ACL reconstruction, it has significant time consuming and this thing. They found that there is no difference in like there is no difference when you use Siam and don't use Siam. That is what there is one study which is quoted in this article.
See, we are working in KM and they are working in a UK hospital NHS.
Samantavas, what do you say?
ना ACL के समय में तो I have never used the X-ray or that means the CM read technique, but that doesn't. Every time I read within 5 minutes, I forget that green. So I have never used that.
Antao sir would have interesting input in this. He is awfully quiet.
Nanta sir just has not unmuted himself.
So he will speak now. Let us wait. Antao sir.
I think Antao sir has got a connection problem.
He is speaking but probably not getting. Narvekar sir can give little bit of pearls about
So
this.
I think
Please.
out of this paper, the message here is even the experienced surgeon can be wrong while making ACL tunnel. And I'm very sure that many of us in our clinical practice must have faced this situation. So how do you solve
Everybody.
this? How do you solve this?
Use Siam. There's a solution is there.
No, no, no. You have made the tunnel and then you realize that it's a wrong tunnel.
Yeah, Roshan, that's why. Hello.
Ah, yes, yes, good.
You look at before making a tunnel. First, suppose I make a 90 degrees flexion, you use a awl and make a proposed site. Okay.
Hmm.
Then you change to another
AM portal.
higher degrees of flexion, 120 degrees. Again, you visualize. So once you see that, it's basically a freehand technique only. Once you get orientation both in 90 degrees and 120 degrees flexion, I will I can change the position before make the tunnel. In that way, you are more near to the what you intended tunnel.
Roshan, a question to all the other seniors like Sanjay and Raghuvir, Antao sir, Narvekar sir. What is how do you recommend the use of the offset guides for the juniors?
Next one.
Yes, I think initially they have to find out their bearings with the offset guide, but offset guide has to be of several sizes, not a fixed size. Because
Obviously, there are 7, 8, 9 sizes are
no,
there.
no, but most of the people end up buying the commonest size, and then they use it for
9 1.
each and every one. So that is where they go wrong. Offset guide has two purposes. One, it will be reproducible. It will give you reproducible distance from the posterior blowout issue or from the posterior wall. And secondly, if your guide wire is not, what you call of good quality, it will prevent the wobbling and other issues.
Yeah,
Because that is
My
also
take on
a,
that, Sanjay.
hmm. Tell me, sir.
Sanjay, my take is that suppose just for the discussion sake, you are taking the 9 mm offset guide. Okay.
Yes.
So you are taking that offset guide from the anteromedial portal, and you are
Yes.
just giving that 9 meter means that means if you are taking your tunnel like 10 millimeter, your 5 millimeter is gone. So that automatically your 4 mm bone is there.
But sir, my suggestion is to first you find out the point, and your offset guide should be in that, in reference to that
More or
point.
less,
If your point is here, your offset guide has to in that plane.
more or less like at that point. More or less try to
Yes,
be as close
yes,
as
yes,
possible.
yes.
Because
So that it will not move. Your drilling point will not move.
Yeah, I agree with.
to my point for the theoretical discussion, just 1 second, Raghuveer. Suppose that for the theoretical discussion, if you take the whole dimension of front to back of the lateral femoral condyle 4 millimeter above the articular cartilage, then only you know the midpoint of it. Otherwise, it is very difficult to find the actual point. Otherwise, you have only the bifurcated ridge.
We can't hear you, Sonendu.
Come again, please.
What is how you take that point, Sanjay?
So that is what that point you have to first decide that point if you are doing it using a ruler method or you are just using a what you call a radio frequency mark that point, go to the enteromedial portal and decide that you are going to remain either anterior or posterior if that your RF point is not correct, and then put your offset guide not it where it goes, but you can always shift it in line with that your posterocentral point and then use that offset point, that is offset guide. That is what I mean to say.
So how many of us use offset guide in your clinical practice? Offset guide and no offset guide. Offset guide,
No, I use offset guide.
offset guide. Raghuveer, eyeball. Raghuveer, you have to
Yes,
unmute yourself. Unmute yourself.
Raghuveer's internet is a bit poor, I think.
Yeah, Raghuveer.
Roshan, for beginners, you have to go with offset guides, especially for patellar tendon.
Okay.
If you are using a patellar tendon, you are much safer to use an offset guide to prevent the posterior oblique, because it doesn't matter with hamstrings.
Okay.
Because the fixation is extracortical.
Ranjit, you use offset guide or eyeballing?
Yeah, always I take the measurement by the ruler, maybe a modified depth gauge or Arthroscopy guide. Then I come to the enteromedial portal and see where it is, and then I cross check with the offset guide. So I take both the things into account to mark my point. Not a single like offset guide only or only ruler method or only eyeballing. So if you take into account 2-3 methods, then it will be better.
Sandeep.
Yeah. Sir, I don't use offset. Means what I do, once I harvest the graph, I know what size tendon or what will be the diameter. So I suppose if it is 8 or 9. So I take 8 or 9 drill bit, take it in my hand, put it inside, and then pass the bit pin over that. So I know how much diameter I'm going to cut posteriorly and inferiorly, how much bone is going to be left posteriorly and inferiorly, and I use that way. And then drill, if I'm using adjustable, then drill for my desired length with that 8 or 9, then drill with 4.5 later.
So you are using indirect offset guide.
Yeah, exactly.
Still, Sandeep,
Correct.
you are
Yes.
more or less is the reverse sort of offset guide. Still, you are using the guide.
Yes.
He's using guide, but only thing is he's
Yes.
using his own guide
Drill
rather
bit.
than company guide.
Yeah, that's also a good thing when if you do not have offset guide, if you do not want to invest into offset guide, that's a acceptable trick.
No, sir, but we come to know, sir, how much bone will be left. We get rough idea. So
No, even if you use the offset guide, you know, because suppose you take the 9 mm offset guide, you drill 5, you know that 4 mm is going to be there on the backside. So it is not the issue of whether the drill sleeve or whatever you use. The idea is you to be 100% sure, you have to use the ruler, and also you have to check at the bifurcated ridge and the old ACL Sarpe fibers. These are the 3 techniques I follow.
Manish Maheshwari, Manish, can you hear us? Manish Maheshwari.
I use offset guide, sir.
You use offset guide. Very good. So I think more or less 19.
There are 19 people. There must be few more opinions, Roshan.
Yes, yes. Dr. Narvekar is, I don't know. Sir, can you hear us, Dr. Narvekar? We can't hear you now. Dr.
Pradeep.
Antao? Dr. Antao, Dr. Narvekar, we can't hear you.
Pradeep.
Pradeep, yes, Pradeep can come and just share
Yeah,
his.
I just said that we can create a poll there. We can see the poll there. We can.
Now cannot.
Okay.
Now we cannot. Okay. So
But
let's move on to the next paper then.
yeah, next one.
I'll request
Sure.
Dr.
Roshan,
Piyush. Yes, yes.
Roshan, sir.
Yes.
Still your question's answer is awaited. If you have made a wrong tunnel and then you want to change it, so are there any tips or tricks how to redo it? Or
Wrong point or wrong tunnel, Roshan, you must come forward.
Yes.
If you have drilled 2.4, that or just full tunnel.
Full tunnel.
Full tunnel, how can you really, without compromising anything, do it?
No, full tunnel is a criminal offense.
No, you put a screw and then you offset it. That is the only way.
We have done that crime many times.
Tell me, show the trick.
It's very difficult.
Yeah.
You can change to over the top.
Yeah, you can change to over the top. That is one. Secondly, in those situations where you have done a wrong tunnel, the best is to do a stage procedure. First, you put either a bioscrew or a bone graft into a tunnel, then leave it as it is. Maybe after 2-3 months, once the graft healed completely, you can come back.
Not acceptable.
Femoral
Tell
tunnel
us instant method.
Instant,
This is not acceptable because by that way you cannot come out of the OT and stay.
Yeah, there is one instant cement currently which is not available in India. But I saw that cement in USA. It has been constantly used. You can use it as an instant bone block. It sets in and within 10 minutes it's ready for drilling. So you can drill through that cement and you can go to whatever level of tunnel you want to use it.
Then how you will convince the patient you are making a single a stage one? How you convince the patient?
Just say one sentence. You are in KEM.
Yeah, see, it's not a question of how you convince. If you make a wrong tunnel, then you have to convince the patient that the bone was not soft and we were not able to put your graft back into the tunnel.
Roshan, question is not the Roshan, just one line, just allow me to tell.
Yes.
It is not the question of convincing the patient and the party. The party will.
Party? Which party?
He means that the patient.
Yeah, patient. It is very difficult. You see that is there is a relation between patient and doctor. When you tell your
agree.
The bone is soft and I am unable to drill it, and if you fix it, very high chances of failure.
Yeah.
He will accept it. Nothing wrong.
No, he will accept.
But Roshan, sir, in a two-stage position.
Yeah, don't you can't jump in and tell him that okay I wanted to drill it but somehow I could not drill it. Then there is a problem. You have to make up a story in favor of you, suggesting that there is a problem with the bone, and then that we have to address that bone issue maybe by second stage surgery, maybe at surgery at later date.
Let us move on to second paper now.
Yes.
This is stretching now.
Yes. Piyush, can you share your screen?
So I will begin and share my screen.
Okay.
Yes. Hope Manish is satisfied now.
Manish is still not satisfied. I think.
Sir, I just wanted to know if
there is any
bailout, but
I agree. There is no bailout. Unless you have a allograft, you can just instantly put and re-drill.
You can just do without drilling a tunnel. You can just go over the top, change your plan.
Okay,
it is better to do it over the top rather than doing it in a wrong tunnel.
Yeah. I'll mute everyone, and then Piyush, you can go ahead with your paper. Just read the topic of your paper.
Yes, this article is very good. Recent article in American Journal of Sports Medicine. It is about ALL reconstruction and modified iliotibial band tenodesis. What they have concluded is it is indicated to correct the intraoperative residual pivot shift. So they have taken patients and after doing the ACL reconstruction, they have checked the residual pivot shift test. and after checking the residual pivot sheet, if it is there, they have made two groups. So in randomized group A, they have done ALL reconstruction, and group B, they have left it like that. So this is a prospective randomized control trial. And basically, I will start with ALL. What is ALL and all? But it was described first in 1879, and the famous eponymous Sigon fracture is attached to that, and it is hypothesized to control the internal tibial rotation and thus to affect the pivot shift phenomenon. That's why they have taken the criteria as pivot shift test, which is residual after ACL reconstruction. So the anterolateral soft tissue function together. This is the there are multiple cadaveric studies on ALL, and they say the tissue functions as in unison, and there is a particular cord-like ligament. But in this procedure, we usually try to attain the physiological endpoint and or the physiological function of that collective tissue. So this is paper by Genther et al. And so they have called it anterolateral complex. And in diagrammatic representation, you can see the ALL here. This is attached proximally near the anterior to LCL and in between Gerdy's tubercle and attachment of LCL in the tibial side. So this is a nice diagram. And then what is our chief concern now? Most of the patients are getting recovered, but 25% of patients going ACL reconstruction have some problems like in knee kinematics and return to sports. And this is average figure. There are multiple papers. One I've quoted here is by Arden. Residual anterolateral rotatory instability is associated with pivot shift test, and it is a factor for poor functional outcomes. So there is substantial evidence that the damage to anterolateral structure leads to instability. There are multiple papers on that. So which are those important structures? They say, some people say that ALL is reconstructible, but there are cadaveric studies. We say that ALL is a sheet of tissue. So I will come to that debate later on in discussion part. Currently, what we imagine is indications for ALL reconstruction is higher grade pivot shift before surgery. But in this paper, they have taken incomplete correction after ACL reconstruction. So before ACL reconstruction, they have not considered anything. But after ACL reconstruction, they have checked and with a machine like for grading of laxity, you can grade it in mathematical terms by some machine. So incomplete correction, they have divided into two groups. How they do ACL, ALL reconstruction? The simple procedure, they take the 1 centimeter strip of iliotibial band, preserving its distal attachment, and the graft is passed superficial to deep around the proximal ACL, then passed again into the bone tunnel immediately posterior superior to the iliotibial band attachment, that is the tubercle. And the tension in the loop graft is increased by pulling the lead suture through the other side of the tunnel. And the tension is adjusted, and the pivot shift was repeated until the grade was same, because they checked the pivot shift in normal limb before the surgery. So
the voice is not clear, I think.
Is it? Hello?
Yeah. Now it's okay.
I will just hold the. So they have checked the pivot shift test before the surgery on opposite side, and to that grade they have titrated the pivot shift and then done the fixation of ALL. This is the diagrammatic representation of the reconstructed ALL, the tunnel, and the passing of iliotibial band around the LCL. This is a paper by Porter et al. The modified iliotibial band tenodesis procedure has been shown to improve rotatory instability after ACL reconstruction in vivo. So this is motivation for this study. Purpose of the study is to determine if MITBT can improve clinical outcomes. So there was a cadaveric study before, whether it can improve the clinical outcomes and reduce recurrence of ACL ruptures when added to ACL reconstruction in patients with residual pivot shift. So our null hypothesis will be addition of MITBT does not influence the patient-related outcomes or recurrence rates. So as I told, it's a prospective randomized control trial with a level of evidences too. So these are the baseline data. So these need to be, these are the confounding factors obviously. So these need to be normalized on both sides. So age, sex, TBS is posterior TBS low, time to surgery, femoral and tibial tunnel, and these are scores used in this study. The patients who had first ACL rupture involving pivoting sports skeletally mature, non-contact injury, no meniscal repair performed, and residual pivots. These are the inclusion criteria. And patients were randomized by a computerized method to group A and group B. And 2 years follow-up is included in this study. So the patient who had bilateral or previous ACL injury, more than 6 weeks injury, or these conditions are obviously excluded. Any associated ligament injury patients are also, even repairable meniscus tear patients are also excluded. These are the scores used: ITDC score, POOS, Lizome score, Tagner activity scale, and recurrence or need for further surgery. So biostatistically, the recurrence was analyzed by chi-square test, and others were analyzed by ANOVA and Wilcoxon test. Results: we had 484 patients operated in this time period, but only 55 satisfied the inclusion criteria, and they were randomized into group A and B, and 27 patients in group A and 28 in group B, and the sex ratio I have given. So these are the results. So we can see POO score in bracket sports recovery. So there's subscales. The sports recovery subscale of POO score had a significant difference, and Tagner activity score had a significant difference. Lizome score had a significant difference, and recurrence, you can see there is zero number of recurrence rate in B. Here B is the MITBT procedure added. In group A, there were 4 recurrence patients. So this is a very significant difference between added ALL reconstruction procedure and normal ACL reconstruction. So discussion in the paper, they have discussed previous studies and the relevant points. So now what we see is the addition of MITBT reduced the risk of recurrence and improved the scores, as we see. And in MITBT, we don't replicate, though we don't replicate anatomy, the physiological endpoint is achieved, and obviously it reduces the anterolateral rotator instability after addition of ALL reconstruction. How did they avoid over constraint? So there is a possibility, some people say that after ALL reconstruction, there is a possibility that it becomes over tight, or there is no physiological movement also. So that they have dealt with by using the control tension, and they have compared the pivot shift to the opposite mean, which they have calculated before the surgery. There are some studies which are referenced in this article. So there are 2 cadaveric studies, Genther and Noyce. Genther, I already told you that it is, they said that it is unlikely that ACL LC reconstruction procedure will restore the sheet-like function, because it's not a cord-like structure like ACL or LCL. It is a sheet-like tissue, so it is difficult to reconstruct, they have said. But they have given one exception: unless the technique restore the ability of the tissues to transmit forces. That is physiological endpoint, which we have achieved in this study. Noise study, what they say, they have used robotic simulator to measure changes in rotational stability and concluded that neither interolateral ligament nor iliotibial band played a significant role. But they have also given exception, that clinical exceptions may exist, such as grossly unstable grade 3 pivot shift test, which we have included. Other studies about ALL, Ferretti et al. In JBJS 2006 reported that extra-articular augmentation of revision ACL reconstruction provided satisfactory outcome in terms of patient-related outcomes, with a 10% risk of re-recurrence, because they have studied only revision cases. So because they have studied only revision, the recurrence rate might be so high. Resende et al. In 2015 analyzed randomized control trials of ACL reconstruction with and without LET. So there was no difference they found in functional outcomes. But what might be the cause is that higher proportion of patients undergoing LET had a normal or nearly normal knee on the pivot shift and attachment test. In this study, we are doing LET only in patients with residual pivot. So this is the main difference between Resende et al. Study and this study. Song et al. In 2006 compare ACL reconstruction and combined procedures for patients with high-grade pivot shifts before surgery. So they have got similar results: higher prevalence of residual shift and in the isolated ACL reconstruction group compared to combined group. So this is the in accordance with our study they have got the result. Although these studies did not find an improved clinical outcome, the data were pulled from studies using variable inclusion criteria. So it was not focused. Soneri Quartet in 2017 studied the effect that an augmentation procedure had on graft rupture rates. So they have studied the graft rupture rate result. And these prospective studies have followed up patients for an average of 3 years and found rupture rate was 2.5 to 3.1 times less in the combined procedure group. So this is also in line with our result. So according to author, what was the weakness of this study? This study was very small, only 27 and 28 patients in each group. And they have given this cause, but I don't think it is important. Potential effect of tourniquet. They have measured the pivot shift before application of tourniquet, and the residual was measured after application of tourniquet. So they imagine there must be some difference, but I don't see that. There was no blinding in this study, so subjective nature of testing might alter the results. What is the conclusion? That this the results of the study have shown that patients with residual pivot shift who underwent augmentation of ACL had a decreased risk of recurrent ruptures, as there were zero recurrence in at LL group, and higher post-operative activity levels as indicated by BOOS and TAS scores. The persistence of a residual pivot shift immediately after ACL may be considered an indication to augment the reconstruction procedure with MIT-PD. In conclusion, thank you.
I have a comment on this paper.
Yes.
Now, what is interesting to note is this modified iliotibial band technique to do an extra-articular procedure was basically started because you can titrate the amount of force that you're actually applying on the IT band when you fix it back on the tibia and when you fix it with an interference screw. You could titrate it.
They have
now,
mentioned...
if we go back to Noyce's study, which was a cadaveric study using a robotic arm to basically check whether there was any rotational instability after doing an ACL reconstruction in a cadaver, he found that there was no necessity to do an extra-articular procedure in his paper. But here, what is funny is, number one, it is important to know whether this was a single surgeon study, because while applying pressure on the medial side, what will decide whether the pivot shift will go away is, number one, the position of the knee, number two, in terms of the degree of flexion, and number two is the amount of force, tractional force, that is applied to the traction sutures that are passing through the tibia. So that they have not mentioned anywhere as to how they did this.
So they have measured the tension using a device. They have not mentioned the details.
Yes. There was no objective measurement.
There was objective measurement. That's why they have compared the tension in that device, maybe some tension measuring device. They have titrated it to the opposite side. If it was not objective,
their endpoint was not tension. Their endpoint was it should be 1 degree of pivot less than the opposite limb. So if you read this paper carefully, that was their criteria. There is no tension in newtons written here, which is obviously impossible to replicate in an operative setting, which we all know. But that was their only criteria. So it's a very subjective
they have divided into
paper.
Three. Yeah, they have divided into 3 categories.
Absolutely.
And it should be one category, like they have margin of error. One category,
One lower.
One lower they have taken.
Then the opposite normal.
But they have not mentioned how they measured. Your question is correct. Even I had this question.
The objective way of measuring rotary instability has been described by Volka Moshal, and his paper is a very, very famous paper. Then there is another study from Roisuk Kuroda group, Masahiro Kurosaka from Japan, Kobe University, and they also describe the technical tip to calculate the rotary instability around the knee joint. And tomorrow on same issue, we are going to have Dr. Andrea Ferretti from Italy. Tomorrow we are having the same webinar at around 4 p.m., 4:30 p.m. 4 p.m. Indian time, where we are going to discuss this rotary instability of the knee in great detail. So Sanjay, Dr. Abhay Narvekar, Dr. Nicholas Antao, Raghuveer, your opinions on rotary instability and how to measure it. Quantification of rotary instability.
Shall I go first? As of now, I do not measure or I do not attempt pivot shift after my primary, garden variety ACL reconstructions. For revision, I am premeditated to add extra-articular tenodesis. As of now, this is my stand because I believe that this re-rupture rate, recurrence rate, or whatever you say, is multifactorial. And my garden variety patients, I am not sure how they will take the additional, lateral side constraining procedure. But in revision setup, I would certainly add this lateral extra-articular tenodesis if provided there is no so-called other intra-articular lesions and it is just pure probably this pivot shift exaggerated position or hyperlex individual who has failed once.
Okay, Atik, you have tremendous work on the rotary instability. I have seen few of your
Unmute yourself.
Atik, unmute yourself.
Yeah.
I seen few of your presentation on the rotary instability. So how do you decide and quantify your rotary instability around the knee? Any?
I have specific indications. Like most of the primary, I'm a little hesitant to do like Sanjay said. Sanjay, I agree with you. Routine primary may be hesitant to put an extra articular, but unless there's a explosive pivot shift, or off late, I've become little more in doing extra articular in people who are hyperlax and in contact athletes. But otherwise, in the routine, this thing I don't do them. Revisions, of course, I mean, that's a different issue altogether. But if you're talking about primary, I think only for an explosive pivot shift and contact sport and hyperlax, I would add.
Swarnendu, Raghuveer, Dr. Abhay Narvekar, Manish.
No, I think clinically, if in case, first thing is without anesthesia, you're able to get a pivot shift with his foot even in neutral or a little bit of external rotation and very little axial force. That is what we mean by saying as a grade 3 pivot shift. So once you find that, okay, then definitely you would basically add enterolateral, whatever, reconstruction or LET. If in case the guy is not a high level athlete or not, like Atik said, does not have hyperextension, then you may not do it.
But
so
sir,
those indications are fairly clear. That's
sir,
what I'm saying.
quantify hyperextension.
No, see, you compare to the other side. When you compare to the other side, you find that this particular side is very lax, goes beyond. But sometimes I'll tell you why. You have to be very careful that whenever there is a hyperextension on that side, then that is definitely no posterolateral, because hyperextension, okay, is if it is more as on the side to be operated than the other, you have to make sure that there is no posterolateral rotatory instability. I think that is very important because most of the hyperextensions occur with posterolateral rather than with anterolateral instability. I think that is very important.
So when we sir, hyperextension, I want to clear with you.
Yeah.
When there is a natural hyperextension,
yes,
say bilaterally, opposite side is also hyperlex, then you would not, correct?
See, what happens is that hyperextension predisposes these people to failures. Hyperextension predisposes these people to failures, and because of that, these hyperlax people, because they stretch out, you put a hamstring graft to these hyperlax, you will immediately stretch out that. I call them as locomotor artists. Okay, you immobilize them for 6 months and the next day they will mobilize their knee. In a day, they will get their range back. These are these hyperlax people where you do not want your grafts to be stretched out. We are not talking about the hyperextension the way you're talking. Yes, and there is hyperextension because that is probably associated with a posterolateral rather than an anterolateral.
Yes, pathological.
Sanjay, the problem is whenever you do a hyperextension patient, if you add something, their gait changes. And that is a problem for them post-operatively for quite some time.
So when I have seen other people, other surgeons operated cases where they have added this extra-articular position procedure in the naturally hyperlex or hyperextension individuals, they come for opinion that this is my deformity, this is a problem,
See,
why can I not do this? So I don't know.
see,
I'm not, able to make up my mind
see,
that
Sanjay,
prevent a rupture or satisfy the patient for
see,
a long term.
see, Sanjay, what I personally feel is, see, you in effect created a flexion deformity for them,
Yes,
right? It's a physiological flexion deformity.
yes.
Now, because what I have seen over time is because you created some kind of thing like this. If you are patient with them over time, because they already have laxity, these tissue tend to stretch out. But till they stretch out, they are going to be a problem because they'll keep coming and telling you that my other side is hyperextending and here it's not going up to that. And they have a difference in gait and it's a problem. But over time, I've seen they stretch out.
So then what is the fun of adding extra-articular procedure when they
See,
are going to stretch out anyway?
because if you do a regular thing and you do not add an extra articular, they are going to stretch out even further. And chances of your graft getting overloaded or getting injured at maybe not get before it gets ligamentized or synovialized, it may rupture. The
So
failure may
is
occur.
it proven? Is it proven?
It's
Sanjay,
not proven. It's what we are seeing.
Okay,
Sanjay,
okay,
I mean, this is what we are seeing. But
okay.
yes,
the
yes.
answer is not final.
Right,
It's
right. It
going
is
to
still
take
work in
time.
progress. Work
It
in
is
progress.
work in progress.
So pendulum is still swinging. We don't know where it's going to settle. Yes,
Absolutely.
Samantha sir.
Absolutely.
Yes, Sanjay and Atik, probably we are also referring most of the time use the Santi study and also the stability one study. That is the Alan Gategood and this one is by the Sonri Cotet. Okay, so they have taken like more than 500 people, and both these studies they have told like if the age is less than 25, if the pivot shift is 2 and 3, and they are hyperlax and they are going back to soccer or the pivoting or cutting sports, it is better to add the LET with your primary ACL. Even the
And she's
study,
a female.
no, no, it's not like not necessarily is a female, because if you go
Female.
back, if you go back to this study, a female is there because if it's a female athlete, they are more recommending. But the criteria are these three: less than
Okay.
25, less than 25, hyperlax, and pivoting sports, and more than 2 and 3 pivot for both the stability and the Santi study. Okay, so thing is that they are recommending is even with the primary ACLs and the lateral osteoarthritis and the stiffness and whatever is not happening with the LET, whatever the modified lemma.
So that is what the lateral arthritis is only when your graft is more anterior. The strip of graft is taken very anteriorly and close to the patella. If you go in the middle, you are pretty safe. There are studies for that also.
Okay, if there is no other comment, I
No, no.
think
Let us, Roshan. Let us take few more opinions.
yes, yes.
Whom do
Who,
you
who
see
else?
on their screen?
Raghuveer,
Whom do you see? Yes,
Raghuveer.
Roshan,
Raghuveer.
your opinion.
Your Roshan, your opinion.
Yes,
Yes.
Your
I was
opinion.
concerned
Yeah, I will
primarily
tell you.
whether
I will
by
tell you.
doing the
I
modified
always
lemma,
do.
whether we are going.
Yeah, I always do extra-articular tenodesis whenever I see a hyperlax patient. That is one. If it is involved in contact sports, few of my patients were martial art patients because I was associated with martial art association and football players. There I have always done the LAT,
Do
lateral.
they stretch out?
They usually not stretch out. They never stretch out.
Do they complain that my this leg is that and
No,
other
no,
leg
no,
is?
no.
No, no, no.
Eventually not.
Even Sanjay,
Eventually not.
Sanjay.
Are you talking in hyperlax patients with
And
them? Or
I,
regular patients?
I operated my own cousin brother where I did he's a good football player. He plays for the FIFA, and I operated his ACL along with the LET. Which I operated around 7 years back, and he's still playing. He's playing at very high level.
So
So
define your hyperlaxity, Roshan.
see, usually I check my hyperlaxity by
So heel to bed distance.
heel to bed distance. If it is more than 5 centimeter, I consider it to be hyperlax.
Compared to the opposite side?
5 centimeter as compared to opposite side. If it is opposite side 5 centimeter, 10 is okay. But if it is more than that, I consider it to be hyperlax.
So then you rule out a posterolateral injury, and then
yes.
So what Narvekar sir say. So that is where I also agree there is difference. But just by them being hyperlax on the both the sides, do we add? That is the question. Your indication, I do agree.
Yes, Sanjay, the thing is that if you, the problem is that we always refer to the Santi study and also the stability one. They are recommending that hyperlax.
I know, sir. You have very eloquently, given the conclusion of their study. That has been, I have come across that several times. But still, Roshan is also doing it for the comparatively more hyperextension on the affected side. That is what he is agreeing to.
I have a question.
Yes.
In this study, they have measured the intraoperative, like after doing ACL reconstruction, they have checked for laxity. So how many of you, I want to know, do that? Because Sanjay sir said he doesn't check pivot shift after doing ACL reconstruction. So are you afraid that it will loosen out by checking, or?
It is senseless to check.
It doesn't make sense.
Yeah. Any other question? Raghuveer.
Yeah. I'll just ask something.
Yes,
Roshan.
Dr. Yes.
Suppose if in case you have a young guy who's a footballer, has got an ACL, okay, and he's got a higher slope. That means he is probably a susceptible guy for ACL, even for his failure. Would you therefore take that also as an added indication for an extra article?
Sir, I'll tell you.
He's not pivot shifting. He's not pivot shifting grade 3.
Yes.
He is a regular ACL guy.
I totally understood your question. The thing is that, first of all, my understanding of this slope has come in last 3 years. Before that, we never used to think about slope. Last 3 years, we have been thinking about the tibial slope and association with the ACL. Before that, we never thought about it. So before that, we always used to consider hyperlax. But now with the great knowledge, we understood that hyperlax doesn't mean only the hyperlax. It could be because of the change of slope also. For that, I had done only one case where I had done an anterior closed wedge extension, deflection osteotomy. I learned it from Dr. This French fellow, David Dijon. He's a wonderful surgeon. He described that closed wedge osteotomy anterior, and simultaneously you can do an ACL reconstruction. But it is too complicated procedure for a player who is going to play at national or international level. But yes, whenever you see a person who has got hyperlax knee along with the posterior tibial slope gone, I think deflection osteotomy along with ACL reconstruction is a better option.
Now tell me something, coming back to what even Sanjay was saying. What about if the slopes are same on both sides?
That is a usual situation. You will always.
Then why do you need to? That guy has lived, let's say, for 35 years with slopes on both sides, has a trauma, clear-cut trauma, injures his ACL. Then you still need to correct the slope.
That's exactly what I'm saying. That you are not going to correct the slope. So are you going to add an added procedure?
That's what I'm asking.
So the
probably in that.
So if you see the latest study, AJSM, they say that if the patient who have excessive slope, so the stresses on the graft, they are much more in patient who have excessive slope, and the graft is more likely to stretch out, especially if this patient have more ramp lesion, then the effect is even more potentiated.
No, that so you're adding other things to it. It's not a simple thing. Patient has an increased slope, let's say 15 degree slope of 12 degree slope, 35 years, 37 years of age, playing soccer, has a cutting injury, here's his ACL.
Yeah, so
both slopes are exactly the same on measurement. Primary ACL, would you do a corrective osteotomy? Yes or no?
No, never. Because last day also in the academic meeting, Wolf Peterson.
You should not do.
I will not do it.
You should not correct the slope.
If unless it is a pathological slope. See, simultaneously, if it is on the same side on both knees, I will not consider it to be a pathological. This is what he is born with.
So
exactly.
So
even if it is 15 degrees, you should not change the slope in primary. Yes, sir.
Yes.
Correct. I'm telling you the same thing, that you are not definitely going to correct the slope. But then you know he's more susceptible. So are you going to use that as an added indication for an LET?
So probably no. That is a gray
Forget
zone.
the rest. You understand?
Undecided.
That is a gray zone. Probably.
Because for bony, you are using soft tissue solution.
Yes, yes.
No. You're not using a You're not using a ball. You know that he's susceptible. So you want to add something more to your ACL. Similarly, you're going to also warn him that he is one of those 30% who are likely to get the other side ACL.
Yes.
We know that these guys are bound to have an ACL on the other side too. And maybe he also may be one of the guys who probably may not do a bone patellar, because we know inherently they are more liable to get a opposite side ACL.
Sir, Dr. Atik sir, you said 37-year-old male and he has a cutting injury. So can you say with conviction in a given patient that his ACL tear was not due to his proneness due to posterior tibial slope, more posterior slope, and only because of injury?
Piyush, no. What we are talking about is, what we were saying is that 37-year-old, same slope on both sides.
Yeah.
No, but
and clear-cut history of trauma.
Clear-cut history of trauma, but can we say with conviction that this was not due to his proneness to tear?
No,
because
not,
there is
yes, because 37, he has almost led his life. So yes, with conviction.
You can probably say that. So what you are doing is, what Dr. Narvekar said, you would not correct it. Probably you would add an extra LET procedure there to correct his, to take control of his rotational element.
Yeah.
Okay.
So one thing is for sure that the native ACL and a reconstructed ACL post-operative are two very different scenarios.
Absolutely.
The native ACL may be able to tolerate that excessive slope for 37 years.
Yeah,
but immediate post-operative ACL reconstruction scenario may not be a good time for the body to tolerate that extra slope, especially as when we are talking about the graft not getting stretched out. So something can be added to for that stretching not to occur. It has been proven that the graft has more stretch than in normal stage. So yes, it either you can put an extra-articular tenodesis or a slope changing osteotomy, but something needs to done to make that patient less prone for graft stretch out.
Probably a LET might be a better option.
So there's an interesting article, I think, done by in JSS Medical College, published in World Journal of Orthopedics about 2-3 years ago, where they analyzed about 450 lateral X-rays of patients that came for patellofemoral problems and ACL injuries. And you'll be surprised to know the variation of slopes that they found, medial and lateral slopes. So in women, it ranged from 0 to about 25 degrees. And in men, it was about -5 to about 16, 17 degrees. Interesting to note, didn't do a patient-reported outcome measure of how those ACLs did. But I think, are we overthinking changing slopes in primary settings? I think it's food for thought.
See, the slopes of Indians is as it is more than the Westerners.
Yeah, slopes of Indian is more than
is much more than Westerners.
So it is a question of over or preemptively treating, or maybe over treating in other sense, or waiting for it fail and then address it. I don't know yet.
Pendulum swinging.
Sitting on the fence.
Pendulum is still swinging.
Swinging, yeah.
So
maybe next year we'll have some answer.
Yeah, hopefully.
Let's move on then.
Let's move
so
on.
what is the message?
Message is wait, move on for next year. Ranjit.
I think.
Yeah, Pradeep. I think we should go ahead with the bruise pattern.
We can go ahead with the bruise. I think so. We can do 2 successive screws article. Okay, we can go ahead with bruise pattern. No problem.
So now I'll request Dr. Pradeep Nemadet, he was studied on the bruise pattern and bruise injury. I think today the time left is just half an hour. So probably we'll split this journal club into 2. Today we'll take three articles, and maybe next Monday we will take another 3 articles which are remaining by Dr. Jigar Desai, Swapnil Keni, and Dr. Abhinav Jogani. That is on reconstruction. So Pradeep, I think we'll finish today's bruise pattern. So this, can you read the article, please?
Yeah.
Just mute everyone.
This article is published in 2020 in OJSM. Some Chinese people, and they have done this study on bone bruise distribution pattern after an acute ACL rupture. So one minute, it's not working. Okay. So before I go ahead, I must recommend everybody this classic article by Timothy Sanders, in which they have given bone contusion patterns at the knee on MR imaging, the footprint of the and mechanism of injury. And the same author also have mentioned the same article in the introduction, that there are 5 contusion patterns that are associated in a knee, like the pivot shift, dashboard hyperextension, chip, or lateral patellar dislocation, out of which the pivot shift pattern is generally associated with the ACL, where we can see that the tibia tends to subluxate anteriorly, and that resulting into the abutment of the entire part of the lateral femoral condyle and the posterior part of the tibia, and that will lead to the footprint or the bony footprint of this. Many of the times we will see this lateral indentation pattern, and that is occurs because of this kind of the mechanism of injury that will lead to ACL injury. So the authors say that the femoral and tibial bruise pattern, they represent the footprint of the impact of ACL at the time of injury, and they generally offer insights into the mechanism of injury. So generally the lateral compartment will tell us that the valgus load is applied, and the posterior tibia and anterior femur, that will tell us that the anterior tibial translation with a small knee flexion angle. So now if you see the frequency and location of the tibial and femoral and tibial bone bruise pattern, they are described separately in the previous studies, and they're not much reported in the relative bone bruise pattern of tibia and femur or the combinations of this. So most studies article, they are focused on lateral medial direction and very much little attention to the anterior posterior direction. So a recent systematic review, they are told that there should be studies which should study the anteroposterior or combination of this bruise pattern also, and taking the clue a call from this systematic review, these authors have did this study. So purpose of the study was to investigate the common bruise pattern, and they hypothesized that the most common bone bruise pattern would be lateral, and they also said that the bruise pattern will indicate that the anterior translation of the tibia with respect to the femur. So maternal methods, they have it's a retrospective study. They have reviewed all their ACL injuries from August 2016 to August 2018. There were around 4,200 patients. Out of that, they have excluded 3,618 because the MRI was more than 4 weeks of the injury, age of either more than 40 or less than 18, and there was non-sports injuries. And out of that, only around close to 590 were eligible for eligible for assessment, and out of that again 384 were excluded because there was prior trauma in the lower extremity, there was PCL injury, there was either a collateral injuries or a poor quality MRI, and for final analysis they have taken 207 patients. So they have taken proper permission, and they have standardized the MRI with the available software that they have. So they define the bone bruise as a bone bruise is a traumatically involved geographic non-linear area of decreased signal intensity on T1 and increased signal intensity on T2. Participants were first classified according to presence or absence of bone bruise. So those who have bone bruises, they were bone bruise group, and they didn't have, they were no bone bruise group. Then in those patients who have bone bruises, they did two things. They first selected the slide of interest, and then they find the location of that site, and that's how they have determined the location. So how did they select the slide of interest? So first they put the MRI into the imaging software, where they just mapped out the area of bone bruise, and they, just like that, and then in that map area they could find something called as the gray value of that area, and based on the imaging pixel, and the maximum gray value on pixel of the pixel and the area of the border region was thus measured, and the slide that showed maximum gray area was considered the slide of interest. Now it is not clear whether they did T1 or T2. They have not mentioned it, but looking at the images, it looks like they have done it on T2. Now, determine the location. So the lateral to medial direction was first determined by using sagittal images sequence, and anterior to posterior was determined by using the coronal image sequence. It looks little confusing how they do that, but I will try to explain. The bone bruise location on lateral and medial and anterior posterior direction of the tibia and femur were recorded separately. So how did they do lateral to medial direction? So this diagram is not from the article, but I have just put it for understanding. So the M max is the number of slice at which the gray value was maximum. So that is called as M max, and M total is the total number of slides. So for determining the lateral to medial direction, they found out that which sagittal sequence slide showed the maximum amount of bone bruise pattern, and then they have divided the slide from 1 to 100, and that location was calculated based upon this percentage method, and thus they have the value of 0 to 100. So 0 was on lateral side and 100 was more close to medial side. Logically, less than 50 would be lateral and more than 50 would be medial, and similar thing was done for anterior posterior. So I don't need to go into the detail of that. That is pretty logical. And this is the algorithm by which how they have done. So what all I have explained has been given in this algorithm. So they start whether the patient has no bone bruise, they will put it into the no bone bruise group. If they have presence of bone bruise, they will determine the mediolateral and anteroposterior position of that, and then accordingly this ML and AP value was calculated. So now coming to the classification. So either the bone bruise would be on femur or tibia. On the femur, they would be either lateral femur, medial femur, or both femur, like bicondylar pattern. Similarly, tibia then can be lateral tibial condyle, medial tibial condyle, or bicondylar tibial condyle. So based on permutation and combination of these, we have 6 different patterns of bone bruise classification. So they have also calculated inter-observer reliability. We don't need to go into detail of that. An appropriate statistical method, the pair t-test, chi-square test was also done, and I don't think so discussing that is the much more importance in considering the nature of today's journal club. So coming to results. So the patient with first they compared the patient, those who had bone bruises and those who didn't have bone bruises. So demographic profile, that was not much of a significant. However, the most important thing that was keen to observe that patient, those who did not have any bone bruise, they have a higher percentage of meniscal injury. So that is the first result. Then based on the patterns, the most common pattern was lateral femur, lateral tibia. The second most common pattern was bicondylar femur and bicondylar tibia. And the third most common pattern was the lateral femur and bicondylar tibia. So that was the percentage 44, 29, 15 of the bone bruise distribution pattern as far as lateral and medial is considered. Then they also did study the anteroposterior location of the bone bruise pattern. And if you see this, that can be done, they compared lateral and medial. So obviously they can be compared only this bicondylar pattern, they cannot be compared into the unicondylar pattern. So they have seen that those patient who had bicondylar femur and bicondylar tibia, the lateral side were much more anteriorly than the medial side. Similarly, on those who have bilateral tibia and only unicondylar femur, again the lateral tibial were much more anterior than the medial sided bone bruises. So comparison of severity in bicondylar femur and bicondylar tibia pattern. So the lateral bruises which more significantly greater than the medial side. So again, those who have bicondylar pattern, lateral was much more severe. Again, comparison of the AP location, I already mentioned that the lateral side was much more anterior than the medial side, as similar was seen in the lateral femur bicondylar tibia pattern. However, the severity of the tibia were equal in this particular pattern of the bone bruise distribution. So inference of the study, the discussion, so it supports their first hypothesis that the lateral bone bruise pattern would be the most common. So similarly, in this case study, the lateral femur, lateral tibia pattern stood out the first, and again those who have the second pattern was bicondylar femur, bicondylar tibia. The lateral was much more severe than the medial. So it is the first hypothesis that lateral bruise will be much more severe or common, that is supported. Now, the similar previous investigation also demonstrated that some studies have done a volume of the lateral bone bruises that was much larger than the lateral was much more larger than the medial. And again, the tibial side bone bruises on lateral side were much more severe than the medial side. As so, the previous reports and this study again they stand in one line. The medial bone bruise pattern now, however, the authors try to explain why medial bone bruise pattern occurred. And they said that it is the countercoup forces of the medial compartment or after resolution of the valgus force. So once you have valgus force and then the valgus force resolves, the medial side will have countercoup force, and that might be the reason for the medial bruise pattern as per the authors. So the implication of that particular result is that the valgus loading in coronal plane could be one of the most important contributor in ACL injuries. And recent studies also in cadaveric has shown that the ACL strain increase much more with a greater dynamic knee abduction moment, and reducing the high abduction force could be one of the preventive mechanism when we are trying to prevent ACL injuries. As far as the relative femur and tibia patterns are concerned, we should focus much more on the lateral pattern to understand the mechanism of injury. Since LFLT pattern is the direct and accurate footprint left behind after the ACL, and that could also provide more clues to the ACL mechanism of injury compared with the other bruise pattern. So future studies should focus on these patterns. Second hypothesis that the anterior translation of the tibia with respect to femur that occurs during ACL injury also, that is justified by the study, and results also indicate. So thus result indicate that abduction as well as anterior tibial translation could be the mechanism of injury. So what about rotation? So there was definite asymmetry as far as the anteroposterior direction of the bone bruise pattern was considered between medial and lateral side. However, so that will tell you that there was some tibial rotation, but the author, they found difficult to infer whether it was internal or external rotation. So thus ACL injury mechanism involved a multiplanar loading pattern. So this is all we know, but it's just another reiteration of the same fact. And the previous study showed that the tibial abduction rotation combined with the anterior tibial translation and external rotation is the major ACL injury mechanism. And this study also potentiated the claim made by the previous study by Quantum. So another aspect of the study which needs interpretation is those patients who did not have any bone bruise and they had more percentage of ACL, more percentage of meniscal injuries. And again, previous studies showed that the existence of bone bruises on MRI were negatively associated with the medial meniscal injury. So again, it just potentiates the previous study. However, the explanation given by the author is that this underlines the shock absorption function of the menisci, and greater function of meniscal injury in patient without bone bruise could be because in these patients the impact force were observed by the meniscus rather than by the bone. But I don't know, means I couldn't align with the opinion of the author with this. The limitation of the study is that they are less female patient, so difficult to compare sex specific differences. Sometimes bruise may reflect the force applied to the knee by specific sports activity. So suppose like each sports, if you see, there are different bone bruise patterns that are prevalent in that, and these sometimes can cause bias. So that the author has agreed. Bone bruises were more severe in non-contact injuries than with contact injuries. So again, that is little bit thing that one needs to look at. And lateral tibial plateau is smaller, and bruise location was based on total anteroposterior depth, not only on the lateral side. So that is again a mathematical flaw which they have admitted. So in nutshell, the things which are coming out of this study, that most common pattern or combination pattern of bone bruise is lateral femur, lateral tibia. Second, lateral side is much more femur in bicondylar tibia, bicondylar tibia pattern. And the anterior translation of tibia related to femur occur in ACL injury based on the location of bone bruises. So the point to ponder, which makes us think, is that around close to 20% of the patient had no bone bruises. And the explanation of medial bruises as a counter-coup injury, again, this needs validation. Means whether that counter coup injury can cause medial bruise or not, or it is just a different mechanism of medial bruise, that needs to be thought about, because that is just an explanation that is given by the author's interpretation. And patient without bone bruises had more meniscal injury. So author explained that the meniscus absorbed the force, but fails to explain why meniscus couldn't absorb the force in other patients where their bone bruise pattern was there. Again, interference need to be looked at. Thank you.
This was a great paper, I think, Pradeep. This was a mind, eye opener for bruise pattern and its clinical relevance in your meniscal injury as well as a cartilage injury. So, anybody has any question related to this paper? Vikram Maskar, Dr. Manish Maheshwari.
Sorry, can you hear me now?
Yeah, we can hear you. Yes, go ahead.
So what is important also in this paper, they've mentioned about the kind of injury mechanism vis-a-vis the bone bruise pattern also. So if there's a hyperextension injury, there is a kissing lesion. That means between the lateral femoral condyle corresponding to the tibial plateau below. And if it's a pivoting valgus kind of force, it is more anterior on the femur and more posterior on the tibia. And another interesting thing about this article is that they say that the lateral femoral condyle bruising is more sensitive and specific for an ACL injury as compared to what we have age-old been reading, that the lateral tibial plateau is a telltale sign of an ACL injury. So in this paper, they actually mentioned the lateral femoral condyle bruising is more indicative of an ACL injury as compared to a lateral tibial plateau.
Sorry to correct, I think the authors have not mentioned that. They have said the lateral combination pattern is more. They have not specified on the femur or tibia. They said this combination pattern. So all previous study had actually told on either femur or tibia. In this paper, the whole gist of the study was to study the combination pattern rather than studying the individual tibial or femur.
Okay.
So there are the 6 combination patterns. They say the LFLT pattern is much more relevant.
Pradeep, there is a question by Dr. Nicholas Antao.
Yes,
and Dr. Antao wants to know, was a O'Donoghue pattern of injury and the hyperextension injuries around the knee are analyzed, or it is a completely different?
I think that was not the purview in the purview of the this thing, because
this
the
paper, right. This was not out of purview of this paper. And was this bruise pattern which was seen on lateral side was not at all corresponding with the meniscal injury pattern?
No, they did the percentages. So meniscus injury percentages are much more in the no bruise patients. Of course, there were meniscus in bruise pattern also, but the percentage was much more in the patient who didn't have any bone bruise.
Yes, Sanjay.
Well, I am just absorbing this information because I never paid such a great, attention to this. So I am absorbing the information, and Pradeep has really very nicely, summarized the paper, and I'm quite happy about obtaining this new information. I would not have gone and read this paper, Pradeep. Thank you.
That is why we have invited you to Journal Club. Tornendu, Vatik, Raghuveer, are you there?
Yeah. Lot many times we are seeing the bruise, but we never understood this is the pattern. So this is the real. We have seen this lateral femoral condyle and the anterior tibial posterior, but we never understood that it has to be seen from a different angle. Pradeep,
I think. Don't you think I think it's an excellent paper, because always we were told that MRI is so sensitive to even a mild touch that it will pick up some kind of bruise somewhere. And to understand, I think pretty brilliant paper here.
Yeah, even
it's not done by me.
Whatever.
For me, bruise was to just stay back and just wait for intervention. For intervention. That was the significance.
This bruise pattern was studied by one of my colleague, Dr. Kumar Swami Dussa from Nair Hospital, and I was also part of the study. This was around 12 years back.
Right.
We studied a lot of ACL injuries, and we took their MRIs, and they found out which side is bruised. But we never did a detailed study what this author has presented.
Yes.
It is really
fantastic.
Good work. Yes, Swarnendu, you had some question?
No. I just told that Pradeep has taken a really nice paper. He's a real eye opener, and I am just like Sanjay absorbing the whole thing.
But what is very tricky about this study is not having the meniscus injury on the side of the bruise, and there is no correlation, percentage correlation. Am I right, Pradeep? If I understand the paper well?
No. So they means the amount of patient they analyzed was too less for that to say that. They just calculated the percentage, and they said that if you have bone bruise, the percentage of meniscus also, again they have also not done statistical significance test for that because it was not applicable. They just said that it is negatively correlated. That's it. And that also without any statistical method. That is just the percentages.
Pradeep, can you put this paper on the group?
Yeah,
sure.
he'll put it.
I think all the journal papers should be put.
I will
already,
put it.
We should be able to download and again go through it.
Yes.
But I think Pradeep's summation or selection of the points from the paper were quite apt.
Dr. Manish, we had a few.
This is the advantage of institution attachment.
Dr. Vikram Maskar, Dr. Ranajit Panigrahi.
Makes us absorb a lot.
Yeah, Pradeep.
Yes,
Hello.
Ranjit.
Yeah, Pradeep, the force transmitted to the menisci in the patients with bone bruise is less than the force transmitted to the menisci in the patient without bone bruise. You mean to say?
No, I didn't mean to say. The author gave the explanation of their results, that why meniscus injury were more in patients without bone bruise. So they thought that the menisci absorbed the injury and they failed, and in those patients the menisci didn't absorb, means the force was directly given to bone, but they failed to explain why meniscus couldn't absorb the injury in this patient. So that is little bit thing, because the author has to give some explanation for their results, and that might not be always correct.
No, Pradeep, I think you're the only one who has understood this paper, and we all need to read it.
Pradeep, there's one observation. We've seen this, that if there is a medial meniscus tear with a ACL with a low velocity injury, very often it is without a bone bruise.
Yes, sir.
So if there's an ACL, but that is not with a lateral, it is with a medial meniscus acute injury.
Yes.
That is one, that has been seen. The other thing I just wanted to know, is this paper only related to isolated ACL tears, or there could be combined other ACL injuries, like posteromedial, posterolateral injuries along with this, because the bruise pattern would change depending upon where the pivoting has occurred when this particular injury occurred. Yeah. For instance, the posteromedial, for instance, associated with the lateral could happen with an associated posterolateral injury. You understand what I'm saying?
Yeah,
so I didn't get the zest of that part of that paper, whether they included that or no.
Yeah, so they have excluded collateral and PCL injuries. So they have taken only ACL and ACL with meniscus. They excluded all the collateral and PCL associated PCL injury.
Okay. You upload the paper, so you have to read it properly. Then only will be probably understand most of the things.
Yes.
Pradeep, because we have been seeing this bruise pattern, especially the injury. When hello.
Sir, yes, I'll just show the exclusion criteria. That posterior cruciate ligament and the medial and lateral collateral ligament were excluded from the analysis. So it is just a pure ACL and ACL with meniscus.
So Dr. Antao wants to know what was the pattern of the pattern when meniscus was also torn along with ACL.
So that is the pattern.
Yes.
Sir.
So even a medial meniscus had a bruise on lateral side?
Yes. So the bruise pattern and no bruise pattern. So bruise pattern will have some patient who have meniscus without meniscus, and no bruise pattern will also have patient with meniscus and no bruise meniscus. Only the percentage were much more higher in no bruise pattern. They have not studied the bruise pattern. Subgroup analysis was not done. I think the number is too small for that subgroup analysis.
The authors are radiologists or orthopedic?
Orthopedic surgeons.
Orthopedic surgeons. They had done ACL reconstruction.
No, was the timing of the MRI standardized?
Yes.
Was it done X number of days after the injury?
So they have excluded any MRI that was done more than 4 weeks after the injury.
think this was a real eye-opener as far as
Music, but
yeah, we wanted this in midst of a very confused paper. Sometimes it's better to have a very good amount of stress busters. So does this bruise pattern has a clinical implication on ACL reconstruction? Because see our the ACL tunnel. No, I'm just asking you as a gist of that paper.
They have not studied that. I think that the other seniors can be in much more better position.
There is a classification system for bruising postulated by Mink. You know, it has a 3-graded system. Grade 1 is in the medullary region alone, cortical or medullary region. Grade 2 is that goes up to the subchondral bone, and grade 3 is beyond that. What they say is when it involves grade 3, then of course it could interfere with your ACL, reconstruction per se, because that's almost like a fracture that you have there, which, doesn't show any displacement. But lower grades, of course, there is no patient-reported outcome measures done in this study. But logically speaking, I think that should make a difference.
Yeah.
Pradeep, you can send it later on the group also.
Yeah,
don't worry about it. You are frankly, we are trying very hard. Frankly, you don't need to try very hard right now. Anyway, Roshan.
Yeah, it was a very good session, Pradeep. I think Jigar, Abhinav, and Swapnil. Can you hear me? Jigar, Abhinav, Swapnil.
Yes, sir.
Please start your videos.
Yes, sir.
Because these 3 people will be presenting. They are all consultant and colleagues at KM Hospital. They will be presenting on remaining 3 papers because already we are reached 6:25, and I don't think so we'll be able to finish 3 more papers. So next 3 papers are going to be on screw fixation, interference screw fixation, titanium versus bioscrew. One is complications of bioscrew, and third is on what?
Third is use of plantaris tendon as a novel graft.
Yeah, use of plantaris tendon as a novel
interesting
graft in ALL. So we will send all these papers on the arthroscopy study group. Pradeep will put it today itself so that people can go along with it, and then we will study it on next Monday. So every Monday we will keep it at Journal Club. Maybe next Monday we'll do that ACL part 2, and after that we'll keep the bone instability and shoulder instability. Thank you.
Great, Rohan.
Thank you.
Thank you.
Thank you, sir. Thank you. I hope